Welcome, everybody, to this webinar on learning healthcare systems as applied to mental health services. My name is Ian Beck, and I'm president of the Graham Boeckh Foundation, and I'm joined today by Alana Ludman, who is vice president of youth mental health at the foundation. Bienvenue tout le monde. Un webinar au sujet des systèmes de santé apprenants pour des services de santé mentale. Je suis Ian Beck, président de la Fondation Graham Boeckh, et je suis avec ma collègue Alana Ludman, et vice-président santé mentale des jeunes. Graham Boeckh is a family foundation based in Montreal. We work across Canada, and particularly in the area of developing integrated youth services, which is scaling up rapidly across the country. The other part of our work is actually global, where we lead a large collaborative of mental health research funders across the world that's working to make research funding more impactful and more equitable. Alana?
So thank you all for being here today to what is we're 10 years into hosting our policymakers workshop, and really the history for those of you who are joining us for the first time is about a decade ago. The Graham Boeckh Foundation started hosting an in-person workshop aimed at senior policymakers working in mental health across Canada. Over the last 2 years, as everything in society, we've shifted to online webinars and have moved from one event a year to two. And so we thank you very much for joining us for the second webinar of 2021. The webinars really were set up with a goal of helping to bring new ideas, share the latest evidence, and bring innovations to policymakers across Canada, really with the hopes that it can help to inform your work in your jurisdiction, as well as create an opportunity for exchange. We hope today's workshop or webinar will allow for that as well, and we're really excited by the wonderful speakers we have today. Before Ian introduces our speakers, I just want to go through a few housekeeping items. Unfortunately, despite really enjoying seeing all of your faces, we're actually going to ask you to turn off your cameras so that we can ensure that the panelists and speakers have their cameras on and you're able to see them front and center. It will also probably make it easier for you to listen and stay engaged. We do also ask that you put yourself on mute unless you want to ask a question, and we can call on you during the Q&A session for that. We encourage you to use the chat to make comments, ask questions throughout, and after you've heard from the four speakers, there'll be an opportunity for you to ask questions, and I'll be pulling from the chat, or you can let us know that you'd like to ask the question directly. I also want to just remind you that this session is being recorded and will be available to you following today. The last thing I will do is ask you to introduce yourself in the chat, and although I've asked you to turn off your camera, we do want you to know who else is here. So please introduce yourself with your name, your title, and where you're calling in from. Je vous encourage aussi d'écrire des commentaires ou de poser des questions en français, ainsi que faire votre introduction par chat en français, et je ferai mon mieux de traduire des questions qu'on aura en français. Thank you all, and back to you, Ian.
Thank you, Alana. So why are we holding a webinar on learning healthcare systems for mental health? Well, I think there's a few different reasons. First of all, I think we see the concept as really extremely promising for improving outcomes for patients and for addressing issues of equitable access and outcomes. Learning healthcare systems, the way I think of it, it's a holistic approach and an integrated approach. And it's one that promotes information sharing and collaboration between patients, service providers, researchers, and decision makers. Through our work in integrated youth services, we've also become quite interested in this approach, and we hope that integrated youth services can incorporate this approach and really become a learning healthcare system. And then finally, I think through my conversations with policymakers and research funders and others across Canada, I feel that the mental health community in Canada is really ready for a discussion on this concept. We're extremely fortunate today to have 4 speakers who have done an incredible amount in their careers to help people with mental illness and develop organized systems to improve the quality of care. I'm not going to go through their bios just to save time. However, you could see we put their bios in the calendar invitation, so you can get more information there. We're going to start out with 2 speakers from the United States who are going to talk about EPINET, which is the US learning healthcare system for early intervention in psychosis. And we have Bob Heinssen, who is with the National Institute of Mental Health, the US National Mental Health Research Funder, and Lisa Dixon, who has been very involved in EPINET and is at Columbia University. Then we're going to switch to a Canadian perspective, and Paul Kurdyak, who is in Ontario, is going to give us a perspective on what are the elements that we would want in a learning healthcare system in Canada, and just some thoughts about how they would apply to Canada. And finally, Amal Abdel-Baki is going to talk to us about a learning healthcare system in Quebec that she and her colleagues have developed for early intervention in psychosis. And with that, I will now pass it over to Bob Heinssen. Bob?
I want to start off by thanking you, Ian, and the Graham Boeckh Foundation. I note that my relationship with the foundation goes back about a decade now, and I want to say that I really have learned a tremendous amount from that association. I really admire the way the foundation approaches the policy process from kind of an entrepreneurial perspective. I've learned a lot about how you guys have gone about building coalitions and spurring innovation in the delivery of care. So I really appreciate being asked to engage in a conversation with you all, where I expect that I will continue to learn quite a bit. So with that, I just have to, these are my disclosures, and I am required to say that today I am addressing you as a private citizen, and any views that I express are my own, and they don't necessarily represent the official views of the National Institutes of Health, the National Institute of Mental Health, or the federal government. So with that, Ian asked me to just introduce the concept of learning healthcare. And before I talk about this, I want to just say a little bit about the US context for learning healthcare. For several decades now, there's been a lot of debate and discussion in the US about how healthcare is delivered, how effective it is, and how costly it is. And in the early 2000s, the Institute of Medicine instituted a series of workshops, working groups, symposia that analyzed the strengths and the weaknesses of the US healthcare system, looked at where it was fragmented, and tried to come up with strategies that might be potential solutions or frameworks that would allow the US healthcare system to become improved. And one of the frameworks that was developed through this process was the idea of learning healthcare. And from a 30,000-foot view, learning healthcare incorporates these 5 principles: that a healthcare system would start by providing the best care possible. And whenever science gives you evidence to say that a particular approach is preferred, you would start with that treatment. you would deliver that treatment in a way that allows it to be measured at the point of contact with the patient, so that you would measure the intervention and you would measure the impact of that intervention on the individual receiving care. And you would do this in a way that you would collect data on individuals and have a system that would make it possible to aggregate data from those individuals across hundreds, thousands, perhaps even millions of individuals or that number of care contacts. And using that amount of data and data analytic approaches, informatic approaches and data science, you would be able to examine the care that was delivered and see how effective it was in real world practice and determine where it may be falling short. And that analysis would give you an idea about targets for quality improvement efforts that would allow you to improve the services. When you launch quality improvement, again, you measure the results of those efforts. And here we look at the variation that might be observed as you're trying different approaches for improving care. And sometimes that variation actually exposes areas where our knowledge, either about the disorder or the intervention, are deficient. And it requires launching new research to expand our knowledge and develop better approaches that then could be tested and implemented in the healthcare system in a rapid way. Putting all of this together, learning healthcare represents kind of a virtuous cycle of starting with the best care available, measuring its impact on individuals and populations, improving it to the greatest extent possible, studying any unexpected limitations or benefits, using that as a platform for new science that would result in even better care at the end of the process. So that's a very compelling vision for how one might set up a healthcare system. And so why has NIMH prioritized learning healthcare since, well, over the last decade? And again, just a little bit of context. So I am the director of the Division of Services and Intervention Research at NIMH. I've been director for 12 years now, and have seen a lot of excellent science, a lot of excellent research that was conducted in academic settings that produced results that were valid and important, but somewhat constrained in that the studies tended to happen in settings that might not be akin to usual care situations. So they produced results that weren't necessarily generalizable. And when real world settings attempted to implement the interventions that were tested in these clinical trials, they found that they would have to adapt them. And the adaptations raised questions about whether what was being done was consistent with what was tested in the science. And we ended up having lots of adaptations that represented kind of one-off approaches to realize evidence-based care. They were done in a way where they really weren't, you couldn't communicate across these various projects. So it wasn't possible to be able to determine whether we were moving forward in any kind of meaningful way. So to sum it up, it takes a long time to do research. It takes even longer for research to find its way into standard care, and even and in the final result, a very small portion of research actually makes it to the point where it benefits patients. The whole area of implementation science was created to address this problem, and here, so we had experience with implementation science, and we thought that establishing this learning healthcare framework would help us promote more rapid and more efficient translation of science into service. We also had experience with measurement-based treatment, particularly in the area of depression care, that showed us that introducing measurement into routine care could help in treatment decision-making and improve outcomes. So we had an idea that that was an idea worth pursuing. Implementation science gave us a way of understanding how we might examine variation in the way that programs were implemented, how services were delivered, and outcomes that patients were achieving in a framework that would allow us to actually learn from that variation. And then finally, the fact that learning healthcare generates multi-purpose data that's useful for a number of stakeholders was extremely appealing. So it generates data that can be used to improve the quality of healthcare, which is important to people who deliver services and administer them within clinic settings. It helps to target areas for further research investment in practice-based research, very important for the National Institute of Mental Health. And then it also gives us a chance to aspire to evidence-based policymaking. And I'll talk about that more in just a second. Oh, I see I'm taking a bit more time than I thought. So I will get to this, move on quickly. So we were able to realize learning healthcare in our early psychosis intervention network, which capitalizes on a very broad and rapid increase in the number of evidence-based treatment programs for first episode psychosis that have grown in the United States. By working with those programs as they were developing and the stakeholders that were participating in those programs, we were able to get some consensus on what would be the key symptoms, recovery outcomes, and treatments that would be delivered and could be measured feasibly across a large number of programs. We've been able to list 101 programs in 8 regional networks that span 17 different states. And those programs have some common features. They all offer multi-component care for first episode psychosis that's delivered in a coordinated way by a team of professionals who offer treatment in a shared decision-making framework. But after that, there's some considerable variation in terms of the patients that are enrolled. About a quarter of them enroll people with affective first episode psychosis. The others specialize in non-affective psychosis. The models differ to some extent, duration of care, for example. Our National Data Coordinating Center is aggregating treatment and outcome data for what we anticipate will be a very large cohort of somewhere between 3,000 and 5,000 individuals. And those data will be able to use at the network level for improving care and outcomes, for state mental health authority representatives to help them build better mental health care systems that address unmet needs, and then finally for the federal agencies that are responsible for financing care, creating better mental health policies. So we have this nice network. We have a National Data Coordinating Center. We have 100 participating clinics. It's an ambitious effort, but it's really only a portion of the ecosystem in the United States for early psychosis care. There are 350 programs that are supported by the Substance Abuse and Mental Health Service Administration. So about a third of them are involved in EPINET, but 2/3 of them aren't. And we feel a responsibility for improving care in those programs. And we've been asking, how can we bridge that divide between the programs in EPINET, which are exploring learning healthcare, and the other programs who may be interested but have not yet been able to join that effort? Well, here we see the core assessment battery that has been developed and implemented in EPINET as being a potential data bridge between the two worlds. This core assessment battery is built on the idea of practical but rigorous assessment, and it provides a way that we can offer these programs a way of sharing clinical data with the National Data Coordinating Center, and that coordinating center being able to provide comparative feedback to those programs that give them a way of understanding how they're operating in relation to the 101 programs in EPINET. This is going to be developed or will come online, this capacity to include the community-based programs. That'll happen in 2022. Now, in addition to benefits for those programs, we're we're providing or will provide tools for state and federal partners who are involved in this larger ecosystem. So in addition to things like participant level readouts, readouts on programmatic functioning, fidelity outcomes, and et cetera, we'll be able to give them ideas about areas that they might target for quality improvement, and then also to pursue empirical policy analysis. So they could look at the policies that they're implementing and evaluate whether they're getting the most effective service from the funds that they're dispensing. We're trying to build our system so that it's aligned with efforts that are happening globally. And here, so today, this is a tremendous opportunity for us to think about how we might capitalize on the expertise and the leadership of our Canadian colleagues. Over the course of my career, I benefited from working with Gene Addington, Don Addington, Robert Sapersky, Ashok Malla, Jay Shah, and I'm looking that maybe we can do work together where we could collaborate to come up with a set of common measures, some principles for data sharing, and joint analyses that would help us learn from our two systems and compare them. So this is my last slide. This is my big pitch. I'm wondering whether we might explore going forward a North American consortium for learning healthcare. This would be a partnership between your system and our system that would promote best practices in early detection and intervention. It would be a collaborative effort where we could look at similarities and differences in early psychosis care delivery and learn from those similarities and differences and leverage each other's experience and innovation for our mutual benefit. So I'm going to be listening very carefully for the remainder of this meeting to see how we might be able to realize that vision. Thank you to my colleagues.
Thanks so much. That's some pretty exciting ideas. So thank you. And now I'm going to pass it over to Lisa Dixon. Lisa.
So I just wanted to thank you very much for the invitation. This is really a privilege to share the work that my team has been doing in New York in partnership with EPINET, and it's always a privilege to follow Bob Heinssen, who's been such an inspiration in the United States and globally for early psychosis care and meeting the needs of individuals and humans who are experiencing this unfortunate health condition in their lives. Like Bob, I have no specific disclosures. I am an EPINET PI. I'm going to be talking today about On Track New York, which is New York State's early psychosis program. And I can tell you that we didn't make this logo. We didn't invent the colors. We actually hired someone to help us do that because we appreciated how much communication and language matter in this space. And again, I'm very grateful to the leadership in the state of New York, Mike Hogan and others, who saw this as an important movement to support as the research was unfolding, and again, as the human side was unfolding. And I just want you to see that over time, the state is committed to expanding this program and to make it available for everyone, regardless of insurance status. And we are about to expand to about 27 or 28 sites with the idea that we're going to keep going until everybody who needs it can get it. Here you see where the program is being offered. Obviously, you notice that there's a cluster. They tend to be where there's an orange hue, and so it actually just raises the challenge of how we offer this kind of program in a more rural area. In order to understand at least our particular participation in EPINET and the learning healthcare system, you need to understand a little bit about an intermediary organization. And I think an intermediary organization is a perfect sort of tool to use around which you can build a learning healthcare system to to make the changes and improvements that you learn about. So an intermediary organization is an individual or a group that acts as an intermediary between two or more entities to promote the implementation of model programs with fidelity and good effect. And it's defined as having a broader role to promote implementation, including building the capacity of providers or systems to implement and sustain best practice models. So we sort of are the go-between. We're between the government, payer, and even the private insurers and the agencies and the participants. And it's our job to help the system move forward. And we're funded. I mean, we're funded by the state. So there's about 10 of us who work in this on this program. So again, just to echo what Bob was saying about learning healthcare, this is the model that we sort of built. I think in some ways, like we built the program originally around something like this, even though we didn't know what it was. And then we said, oh, I think we're trying to do a learning healthcare model. And so this notion of that you have an internal and external scan, which is kind of in some ways the identification of the best practices. I do want to emphasize that that this pursuit of stakeholder, what just happened there? Stakeholder input, that's what we call it, is very, very important. And the stakeholder input doesn't always come in the form of measurable concepts, and it doesn't always come in the form of p-values and rating scales. It comes in the form of the human experience. Then we design care, we implement it, we evaluate it, we adjust. And as we see variation, we and where we can do better, we once again revise, test, measure, and then apply the results of what we've learned. So that's kind of how we've thought about this. And another really important on the ground concept. I mean, Bob talked about it, but it's data. And so I wanted to show you how our data system was built and how it has kind of grown. And you see these 4 key players here: the Office of Mental Health is government, OnTrack Central is the intermediary organization, and then we have our teams which sit within clinics, which sit within agencies, and we work with multiple types of these entities. And then of course we have our clients and families. We even before EPINET, but with EPINET, we get feedback from the clinicians on each client quarterly, both at the client level, and then we also get information on the program. And we are now with EPINET getting self-reported feedback from clients, and that's every 6 months. And then that information information goes to the Office of Mental Health because they have a legitimate interest in this QI process. This is not research. This is really about managing the system. That information is appropriately sort of organized, and it's sent back to OnTrack Central, which then we feed it back to the teams in the clinics and the agencies. With EPINET, we are now able to be working on feeding the information back to clients and families and making it work for them. We also then, the data are used for data science, so for research, for QI activities. And I want to emphasize that the QI activities can be at the team level and at the overall program level, and you'll see that in some of the data that I want to show you. And then I emphasize stakeholder feedback, which I do feel is a little bit underappreciated in the learning healthcare frame. And I think in our world now, we have to really pay attention to that piece of it and sort of think about how we want that piece of it to be integrated within the learning healthcare system. So we have our 4 players. We have a youth and family council. We've created something called an arcade, which is one of the ways that we get feedback from our participants. We do very, very structured self-evaluations of our own technical assistance and solicitation of needs. We have a provider council. So again, that's how we try to get feedback from the various stakeholders. And then I can tell you for sure that we get a lot of feedback from the Office of Mental Health, and we have an executive committee. So that information, once again, gets fed and used in data science. It tends to be more mixed methods, qualitative data, quantitative data, and again, used for quantitative for QI activities. And again, I don't have a lot of time, but with EPINET and the power of EPINET and the, on every level, this whole process is enhanced. So I'm going to end with some data. What you see here, these data are provided routinely. Okay. So what you see here are 3 different programs, and this is the statewide. That's the percentage of individuals enrolled in school or work, recent quarterly rates with statewide comparisons. So you see here 2020 to 2021, and you see the rates. This is our standard. This is what we're expecting based on what we've seen over time, and for people at various phases of the intervention. So people who are earlier tend to have lower rates, but people who have been in the program longer have higher rates. So we sort of aggregated it. And what I want you to see here is you see variation. You see one program that has exceeded the expectation. You see another program that has sort of bounced around, but clearly they're making some progress. And we, that this is a program that may very well have implemented CQI types of activities to get from 54% to 64%. And then we have a third program that something curious happened. They really dropped, right? From 61% to 45%, and this notion of non-judgmental inquiry. So that's where we said, what's going on? And we looked at the situation, and this is a program that is in a particularly impoverished area and more vulnerable to the impact of COVID-19. So this situation requires some different sort of dialogue and teamwork. So here's an example of what I would call sort of team level variability that then elicits responses both within the team and from OnTrack Central, and then from the state, and then ultimately, as we do this with EPINET, you can really tailor the sort of the quality, the understanding of the intervention and the quality interventions, the quality improvement interventions. Here's a slide that just shows you our expectations regarding family participation. And the main thing I want you to see here is that every program at every time point exceeded our expectations. All right. So this isn't, if we wanted to increase our expectation, maybe we could that's something that we could do, and then we'd have a slightly different challenge. But for the sake of right now, programmatic at the level of each program and overall, we are sort of comfortable with where things are. In contrast to percentage of individuals with weight assessment. And what you see here is that not a single program, well, this is organized regionally. So these are not individual programs, but we can look at regions as well of New York State. And what you see here is that none of them get really close to what is expected. And so we really have more of an OnTrack New York-wide problem that we have to deal with. It's not really a program or agency problem. So that's what I wanted you to see the difference. And then the last sort of example is, again, this notion of measurability and stakeholder input. And one of the things that we learned from our family and consumer councils was that a lot of the potential clients, just even when they were learning about OnTrack New York and even early on in the treatment, just were so confused by it and didn't know what it was, and no matter with all the explanations, just didn't get there. So what we did was we created an infographic. So this was a response to feedback that we were getting, We haven't measured whether the infographic has improved things or not. I'm not sure it's worth the time, but anyway, I see that as part of the learning healthcare process. So I'm going to conclude just by saying that, the key ingredients of our learning healthcare system, and as we contribute to EPINET, is support for data collection, support of the intermediary organization, participation of diverse stakeholder groups, knowledge and skills in data analysis, and willingness to change and learn.
Great. Thank you very much, Lisa. Now I'll turn it over to you, Paul.
It's a pleasure to be here. Thank you to the Graham Boeckh Foundation for the invitation, and thank you also to Lisa and Bob for just an excellent overview of the development of a learning healthcare system that delivers and measures and provides oversight for early psychosis intervention care. I am a psychiatrist at the Center for Addiction and Mental Health, and I have a reasonably new role as Vice President Mental Health and Addictions Clinical within the Mental Health and Addiction Center of Excellence in Ontario Health. And it is, it's considered, according to Lisa's definitions, it would be an intermediary organization between the Ministry of Health, who sets policy and funds, and the agencies and service providers who deliver services. And so we're just getting going. And I wanted to take a step back and give you, so what you've heard from Bob and Lisa are sort of deliberations on how you go about developing a learning healthcare system in the delivery of early psychosis intervention care. I noticed that Dr. David Clark from Oxford is in the audience. He has presented before to a Graham Boeckh audience and has presented extensively and generously in Ontario about his development of a world-class learning mental health system and his improving access to psychological therapies in England. Both great examples of how you have that feedback loop that develops through data. I also want to I want to speak to the policymakers about kind of normalizing this, that in Canada, in every province, we have learning health systems. Every cancer system in every province has been a learning health system for a couple of decades, and I know that from personal experience, from having a family member go through that quite recently. What is so different in my experience of my family member going through the cancer system is that while it was certainly stressful having a diagnosis, there was nothing to do. The system came into play. Once the diagnosis occurred, there was systematic staging. There was evidence generated that a bunch of experts vetted. There was treatment that was provided according to evidence. And because of this learning health system and the establishment of regional healthcare centers that are overseen by an intermediary organization that has access to massive amounts of data that they use in real time and over time to generate evidence, the care that we received in Toronto would be the same as the care somebody would receive anywhere else in the province, but precisely because of that fidelity to standards, rigorous application of outcome monitoring feedback, and the opportunity to integrate new evidence as we go. So in comparison, I would say every 2 weeks, I have somebody calling me to say they have a family member in trouble from a mental health perspective, and can I help them access services? So completely different scenario where it seems like we have to make up new rules every time there's somebody who needs help, which is another way of saying, for the most part, we do not have a mental health system in Ontario. I won't speak for other provinces, and that's something we're working to develop based on the kind of learnings and applications. The last thing I'll say is that really the measurement agenda, I would say, is an equity agenda, and what I mean by that is, we've been doing that for cancer for ages, but we also across the world, and certainly in Canada, within a very short time after the onset and the sort of the learnings of a brand new microorganism, COVID-19, all of a sudden we had daily counts of cases, daily counts of hospitalizations, daily counts of intensive care unit hospitalizations, and daily counts of deaths. And so I would posit that here with the data proposition that supports learning health systems, if you are not counted, you don't count. And we have not counted people with mental illnesses and addictions. It was a major source of frustration for us to, in the midst of like daily counts of COVID-19, that we could say nothing with some exceptions about the impact of COVID-19 on individuals struggling with mental illnesses and addictions, despite the fact that there was tons and tons of anecdotal evidence to suggest that this was something of a priority. And therefore, we were really hampered in our ability to proactively plan. And that's really what I want to talk to you about. So this will align with the conversation that Bob and Lisa spoke about. And what I like to think about is not so much data for data's sake, but what are the problems that data need to solve? So when we think about the cancer system, they know every year how many cases occur regionally, and therefore plan and fund for those number of cases regionally accordingly. So we need to know something about the population in need. I would argue that our current state of mental health system access is not meeting the needs of the subpopulation of individuals who are seeking services. So I'm not sure that the highest tier, understanding the population need, is our greatest priority, not because it's something we shouldn't do, but because I don't believe we have the capacity to address the need, the total need that's in the province. So the middle and the bottom tier are really the learning health system components of data. So we are working hard to figure out ways to standardize data that are collected at the point of access. The point of this is for us to understand the populations who are seeking care, and to be able to measure wait times as a point of access accountability. And we also have incorporated into our provincial minimum data set measures of equity, income, work type, ethnicity, so that we can understand over time and course correct whether or not we are meeting the populations we expect to be meeting on the basis of our knowledge of the sort of the race breakdown of our population. In other words, are the people who are seeking care representative of our total population, or do we need to course correct to increase access to certain populations? And so this will allow us over time, and not just with early psychosis intervention, but for many different types of services, realign what is being funded with what is being needed. So this is a really important bit of information. And remember, those regionalized cancer centers are where they are because of data telling them where they need to be and how much service they need to provide. We have no such planning capacity in our province to do anything of the sort. And so what we have is a network of grassroots organizations who are very well intentioned in doing their best, but who are ultimately working in the dark. And I'll tell you what I mean by that in my next couple of slides. And finally, the other critical component of learning health system is understanding the extent to which the services that are provided are adherent to an evidence-based standard and generating outcomes. And that's really the basis of the feedback loop. So you really need all these sources of information, and there is a fourth bit of information. We really need to understand the experiences of the healthcare system from the individuals who are using it, in order to make sure that at the end of the day, it is a service that we provide. We need to understand whether it is meeting their needs from the perspective of lived experience. So here's, at a very high level, our thinking around infrastructure that we critically need to enable us to do the kind of learning health system work that David Clark presented earlier and Bob and Lisa just talked about. And this is our problem statement. We need information about who receives which services from whom, when, and at what cost and with what effect. So on the very left, we have created a provincial data set, and we are starting in the community sector in Ontario. So by the end of March 31st, we will have standardized minimum provincial data on everybody who comes to seek treatment at to 15 or 20 of our largest community mental health and addiction agencies, and then we'll expand from there. You also need a measurement-based care solution, and this is to be able to measure outcomes from the services that are required. Lisa mentioned this. She mentioned, and Bob did too, a national data repository. We need to build within Ontario Health a mental health and addictions data repository that can handle the information once it starts rolling in. And we also need some pretty sophisticated data scientists to provide us with data analytics so that this is not just a measurement exercise, it's a data use and problem solving exercise. And like was said in previous presenters, the same data will support clinical care, will support quality improvement at the program level, and will support system monitoring at the provincial level. The exact same data will flow in and support all three levels of service. So I'm going to end just because we are highly invested in focusing on early psychosis intervention, and we've leveraged our population-based data, my team and I. We know how to identify every new individual in Ontario who has a new psychotic diagnosis. And so there are lots of things that we know. We know that if you are diagnosed in a hospital setting, and this is 16 to 40-year-olds in the study, 1 in 25 of them will die within the first 5 years. This is a lethal illness if not treated. If you're diagnosed in an outpatient setting, 1 in 40, 16 to 40-year-olds shouldn't die at all. So a 2.5% to 4% mortality rate in that age range is shocking. We know that work led by my colleague Cihr, the vast majority of these deaths are suicide. And we also know that at least in one region, we've taken an early psychosis intervention program, one of our provincial programs, and linked it to our provincial data. And my colleague Kelly Anderson from Western University worked with me to show that even though this is a regional program, that program is only capturing half of all individuals who had an early psychotic event. So it's a regional program. Imagine if we had a regional cancer center that only met half the needs of individuals with breast cancer, lung cancer, or prostate cancer. Or imagine not knowing that. So that's the thing I want to stress is this should not be research. This should be performance monitoring. We should know this, and this should be an indicator, and we should course correct, plan, fund in a collaborative way. The final piece I'm showing you is work that Kelly Anderson and I did, where we compared individuals in London, the blue line, who got access to the early psychosis intervention program, which is a 2-year-long program, compared to those who didn't. And you can see there's an 8-fold increased likelihood to die over those 2 years if you do not get into treatment. And so again, this is the kind of thing that we have to do because of research. With the kind of data proposition, these are the kind of things we would know routinely. We would be able to have better reach, better quality, better outcomes. And so this is what I wanted to share with you is our thinking around foundational work to take what is a wide array of mental health services that have been developed in a grassroots kind of way, and creating sort of a vision for a data infrastructure to help bring the sector along. Early psychosis intervention, we hope, will be one of our early areas because we can draft off the excellent work by Lisa and Bob, in the same way that providing province-wide cognitive behavioral therapy and other evidence-based therapies is drafting off the work of David Clark in England. So I'm going to stop there, Ian. Thank you.
Great. Thank you very much, Paul. Over to you, Amal.
Thanks for inviting me today. I'm going to present our CHUM, which is our learning health system for early intervention in psychosis. We have launched this pilot project to monitor and guide real-time implementation of early intervention for psychosis services in Quebec. So the principal investigators of this project are myself, Dr. Cihr, and Manuela Ferrari from the Douglas Research Center, and Marc-André Roy and Annie Leblanc from Quebec City at Université Laval. So to summarize Quebec EIS landscape, since 2017 and again in 2020, the Ministry of Health and Social Services has invested important amounts of money to improve EIS implementation, and they published in 2017 the Cadre de Référence, providing guidelines from Quebec EIS, and offered implementation support through an EIS specialist as well. This resulted in an important increase of the number of programs, rising from 18 in 2017 to 33 in 2020, and are involved in these programs more than 225 healthcare professionals, 60 psychiatrists, and about 2,700 active patients, which should increase in the next few years with about 1,400 new cases per year. Our pilot project involves 11 clinics within 10 different regions, 90 plus healthcare professionals, 33 psychiatrists, and 10 team leaders, with 1,700 active patients with about 750 new cases per year. It also involves 5 patient partners and 4 family partners, and a partnership with the Centre National d'Excellence en Santé Mentale, now integrated within the Ministry of Health and Social Services, and also the Quebec First Episode Program Association. Our project also involves like 11 sites, which were selected for their representativity of the diversity of Quebec reality. So they're involving sociodemographic, like different programs from different sociodemographic settings, such as urban, semi-urban, or rural catchment area, which have also like different sizes, which involve different travel time and distances, availability of public transport, and also different population density, number of incident cases, and also specific vulnerable or minority populations such as Indigenous, newcomers, homeless young people. They also represent different team size ranging from 2 to 16 full-time equivalent case manager, different years of operation. So some programs were only existing since less than 2 years when the project started, and others were there for more than 20 years. The programs were also selected for the many different challenges they were facing in terms of implementation. And the common thing was that they were all committed to improve their clinical services and ready to change. So a learning health system is much more than data collection and measurements. It's a community of practice that collectively use data, create new knowledge, and share to improve care. And this is a major difference in successful engagement of all stakeholders, including clinicians and service users in the learning health system. Therefore, inspired by the patient-oriented research, all stakeholders were involved in all steps of the development and implementation of the learning health system and its evaluation. So you can see here the logos, which you will see in other slides, of our stakeholder group. So the researchers, the clinicians and team coordinators, the service users themselves and their families, the administrators or managers, and also the decision makers at a provincial level. So as I mentioned, all stakeholder groups were actively involved at all steps of the learning health system. So from the choice of indicators, which were more important in terms of impact on youth and more realistic to change or to be changed within the time frame of the project. They were also involved in the creation of an ongoing adaptation and improvement of the data collection platform selection. So both in terms of the display, accessibility, ease of use, but also they were involved in the choice of the questionnaires and the question even formulation. Finally, they were involved on the creation of the feedback, so on which variable we would first focus to offer feedback to the different stakeholders, the content of the feedback, and the formatting and presentation of it. When the feedback were done, then the different stakeholder groups would receive feedback, and from those they could set goals for themselves for improvement, and we would then organize capacity building activities. So all target audience of the learning health system were also involved in the KT components, which involved the creation and animation of the community of practice, which is a very important component of the learning health system. All were involved in the choice of the type or format of training and the active participation also, their active participation in the KT workshops. Finally, we are again measuring clinical outcomes. I will explain how after, and also the transformation of clinical practices, but we also wish to measure the data-informed changes in decision both at program and provincial level. And again, we measure the indicators again. So this figure illustrates the EIS treatment, which involves different essential components which are targeted by this CARPEP. These targets refer to 8 categories of indicator which were prioritized by consensus by our stakeholder groups for their importance in terms of impact on service users, but also possibility to change. So these indicators refer to referral process and delays aiming at reducing the UP, which has a direct impact on outcome. Also on youth and family engagement and satisfaction with services. The youth self-evaluation of 11 domains of their recovery, and a range of evidence-based and recovery-oriented interventions such as CBT, IPS to go back to work or studies, family interventions, integrated substance use intervention. The other category was appropriate clinician to patient ratios to allow adequate intensity of care and outreach, and also continuous education to ensure quality of the different interventions. So here you can see that all indicator categories had different sub-indicators, but I won't go into details to those. So the next step of the learning health system is the technology use. So every 4 months, the team leaders respond to a questionnaire of implementation of essential components on REDCap on the electronic device of their choice. So they could do it on their computer, their phone, whatever. And these were available when and where they wanted. For the similarly, the service users are invited to respond to a 2-question satisfaction survey on the happy or not tablets that were available either on the walls of the waiting rooms or with a QR code on the electronic device of their choice. Youth were also invited to respond on REDCap to a 10-minute, more detailed questionnaire about their satisfaction of services and their evaluation of 11 dimensions of their recovery, which, for example, could involve their mental health, but also their relationship, their employment situation or housing situation in a perspective of global health, and also the impact of the services on these dimensions. Families are invited to respond on about 5-minute satisfaction in-depth questionnaire about their satisfaction with the services that themselves receive, but also the services received by their loved one, including the case manager services, psychiatrists, and also, for example, group interventions. So the stakeholder can receive real-time continuous feedback illustrated with graphics, which I will show after as an example. And the graphics illustrate the degree of implementation of certain essential components. So they can see the evolution in the implementation of components over time throughout the study. They can compare themselves to other EIS, and they can also compare themselves with the Cadre de Référence standards. And also the rationale behind the recommendations are explained, as well as advices on how to improve. And the advices are automated but changed according to the performance of each program. So here you can see an example or 2 examples of feedbacks that were received by programs. So we can see I'm not sure if you see my arrow, but you can see like in blue, like the target of the standard that is showed here of the Cadre de Référence. This is the mean performance of all programs of Quebec, and the program itself sees its performance in green, and you can see also like the programs that performs best and those who have the longer delays between the reception of referral and the psychiatric evaluation. On the right side, you see another example of feedback, which show another indicator on continuity of care. So positive feedback are always presented first for the purpose of positive reinforcement, and the rationale behind as well as advice are then adapted depending on the performance of the program. This is another example of feedback on the satisfaction, where programs can see how their patients are satisfied with the services over time, and also what are the components that make them more or less satisfied. The capacity building activities help to use data effectively to improve the quality of clinical practices and align them with the cadre de référence standards. So they take the form of knowledge exchange events, which could be live or virtual. They could also have online training, asynchronous or synchronous, and also the co-creation of tools that can be shared, tools that could be both clinical or administrative, and finally mentoring between programs with those performing better, helping those with more difficulties. We have all those tools also and references on our online library on our website. And finally, our evaluation of the learning health system showed that we could reach the target audience, and they adopted the learning health system, and the effectiveness on outcomes and the implementation barriers and facilitators are still in progress of studying, as well as the maintenance objective. So we could see here that the ability of programs to improve is still progressing, but has been also reached for many programs, and that in terms of reaching standard, it's still improving in progress since the beginning of the project. So the next step could be the deployment of our early learning health system throughout the Quebec province to all programs if the Ministry of Health is interested. There has been also interest from other provinces' researchers, or maybe also collaboration, as Bob has suggested with our colleagues in the US. Could it also be used for fidelity assessment? This is now being studied compared to file audits, and eventually this could be transposable to other standardized model of care, such as ACT teams or youth mental health teams, such as Air Ouverte in Quebec. Thank you.
Great. Thank you very much, Amal. Through the course of planning this webinar, I became aware that actually learning healthcare systems is something that our National Health Research Funder, the Canadian Institutes of Health Research, is very interested in. And so I thought that as this would be relevant information for this webinar, that I would have someone from CHUM just say a few words about their interest in learning healthcare systems. And I'm happy to welcome Tammy Clifford, the Vice President of Research Programs at CHUM. So Tammy, over to you. And if you could just be fairly brief, that'd be great.
Will do. Thanks so much, Ian. And good morning, good afternoon, good evening, everyone. I'm very pleased to have been able to attend today's event, not only because I'm passionate about the content, but also to share some exciting news that Ian just hinted at about the learning healthcare systems approach that we at CIHR will be taking. And so at present, I am the VP of Research Programs at CIHR. But fairly shortly, I will be becoming CIHR's first Vice President for Learning Health Systems. This is a new role for the organization, brought about by CIHR's new strategic plan, which has a specific priority dedicated to integrating evidence in health decisions, which, again, I know all of you know this, is very much aligned with learning health systems or learning healthcare systems. In my new role, I'll be establishing a new portfolio that brings together some of CIHR's existing functions, notably knowledge mobilization, capacity building, ethics, and Canada's strategy for patient-oriented research, or SPORE, along with some new functions, notably clinical trials and research excellence. We're still at the very early stages of this transformation, but suffice to say we, and those who contributed to the extensive consultations that shaped our strategic plan, very much believe that it's this focus on learning health systems is long overdue. It goes without saying that CIHR, as a health research funder, isn't a learning health system in and of itself, but rather that we see a role for us in supporting learning health systems across the country. All to say, we'll be doing further engagement to help shape the work of this new team at CIHR. And again, we're so thankful to be part of today's conversations, as it's extremely helpful to shape my thinking. So merci encore, thank you again, and back to you, Ian.
Great. Thank you, Tammy. And now I'll pass it over to Alana for the Q&A session.
Thank you,
Alana?
Tammy, and thank you to all of our speakers. I will encourage our speakers to turn on their videos again and encourage all of you to ask questions in the chat or let us know if you want to ask a question. N'hésitez pas de poser des questions en français si vous voulez. Je sais qu'Amal, bien sûr, pourrait répondre en français et sinon, je pourrais faire la traduction. Maybe to get us started, I have a few questions I've been saving up through these presentations, and I'm sure my questions could last a long time. But one of the things that struck me through all of your presentations was really, I think you did a wonderful job sharing a lot of what's working and how great the opportunity is and how learning health systems are really helping to improve care. And I'm just wondering if any of you would be able to speak to some of the challenges that you've had in implementing. And maybe I'll start with our friends from the US, because I know you're further advanced with EPINET. So I'm wondering, Bob or Lisa, if you want to just briefly talk to some of the challenges you've had, maybe how you address those. Lisa, there you go.
I can speak to challenges. I think getting the buy-in of really all the clinicians and to some extent the participants is very it cannot be the importance of that cannot be overestimated. And I think that sometimes it's difficult, depending, there's a lot of variability by agencies, by programs, and they get differential levels of support from their agencies and programs it does take time. It's not, the data reporting and the learning, even the TA activities are not free. And so I see that as a challenge, and it's highly variable across programs, and actually somewhat unpredictable to me.
It's sometimes it's scary to me how close Lisa Dixon and I come when it comes to identifying things like this. I would elaborate on that in saying, I think one of the advances of learning healthcare is that it's supposed to create a new culture around the care experience and the investment in learning about the care experience. And that includes the person receiving the care, the person delivering the care, the people administering the care, and a new relationship with researchers who are now part of the cycle. They're not the dominant party within this process, but they are one component of it. And getting from the real to that ideal has proved to be a little bit more challenging than I anticipated. And in my mind, I think NIMH needs to do more work on what we can do to help further push this idea about the advantages of changing the culture around research, practice, measurement, in care, feedback that's relevant to all parties so that they buy into this as being a better way of doing business.
If I may add, in terms of challenges, I think one of the important challenges that managers and clinicians need to have dedicated time, to have the time to plan and to invest in the learning health system to improve the care. And also, I would emphasize what Bob mentioned, like the change of culture. We often think about it like clinicians that should change their way of doing things and doing measurement-based care, which I also approve. But I think also as researchers, we need to also change our culture and see how we can measure things that are relevant for patients and clinicians. Because what we observed is that really building the system with them made us probably choose indicators that were important to us, but it might not have been our first choice. And by first choosing what they found important, made them engage more in the system. And they were even at the end like asking us to measure more indicators and go more in depth because they did find the utility of the learning health system. And I think that this community of practice, which also involves patients and families, discussing with clinicians and researchers all at the same table about the findings of the research, was also a very a key for the success of the learning health system. I would say that our next challenge will be to engage programs that might be at first less interested in the learning health system, because we, of course, like chose programs that were dedicated to change, even if some of them had a lot of difficulties at the beginning and even wanted to drop at some point. But we tried to adapt to their availabilities, and that also worked.
The only thing that I would add, and those are great answers, is that the challenge in sort of our role with the Center of Excellence is, where do you start? So you've heard here, early psychosis intervention is a great place to start. And how do you manage expectations for people who want to start, who want to start doing this, but don't have the same kind of key ingredients? Like, they don't have evidence-based standards, they don't have an identifiable population, they don't have, they have fuzzy outcomes. So you have to kind of get them there. I'd say the flip side also is that, in a sector where I think we have to be honest about the fact that in a sector where, unlike, say, what I described in cancer care, your accountabilities around funding are, just determining your volumes. There is a benefit from that sort of level of accountability, let's say. So I think that I think we also have to think through like the kind of things that were discussed before. Finding your champions, finding community practice, getting people excited about working together to improve quality, improve outcomes, including engagement of patients. And the final thing I'll say is that, what was described today was incredible infrastructure for early psychosis intervention treatment. For us provincially, we have to think about building infrastructure that will be utilizable for anything we do. So if we start with early psychosis intervention, can we then leverage the same measurement-based software for addictions treatment, or depression treatment, or DBT for personality disorders, et cetera, et cetera. So really optimizing the approach and infrastructure that goes just beyond, because we can't build separate infrastructure for early psychosis intervention, blah, 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 blah. So we have a unique opportunity to think about centralizing the infrastructure and really having volume-based capacity in this area. But all those things, so it's like everything, the challenges are also the opportunities, but it is a lot of heavy lifting.
Thanks. And that's a good segue to another question that has come in, and I'm realizing there's quite a few questions, so we'll try to get to as many as possible, but if not, we can think of how to answer them in our follow-up to all of you. But I'm conscious that learning healthcare systems take time to develop, and EPINET has been at this for many years. And so I'm wondering, given that there are quite a few policymakers and funders who are listening in today, what might you suggest that they do to help foster learning healthcare systems in Canada? Or what might be some steps they could take to get this going further in the mental health care system.
I agree with maybe if I may say, like with Paul, that there needs to be champions, like both researchers but also clinicians to be involved. And I think really planning and dedicate time and human resources to building those systems, animating them as well is very important, because we often expect clinicians or administrators to collect data or furnish data without having time to plan it and integrate it in the system. So I think this is an important part. We can't hear you, Lisa, you're muted.
Building on the strengths that you do have, right? So, you know, there's probably some data being collected, right? It may not be all the data you want or all the data, you know, your fantasy data, but it starting to work with that and getting, again, the stakeholders / champions who can help you shape it and use it, show how it can benefit everyone. But, you know, just start with what you got, you know, and be a little bit creative, and then you can add more and add more. But I do think that a lot of systems collect tons of data. They just don't use it in a way that really helps people. It may help the bottom line, but it may not help people, at least in the United States.
I would say that, you know, as it relates to the policymakers, I think so. I think there are a couple of truths. One is that the reason we're having this webinar today into talking about measurement-based care and mental health is because we are in the midst of a public mental health moment. We would not have been having this conversation 20 years ago because nobody cared, because of stigma. So I think that's a really important point to be made. And so to the extent that we are in a public mental health moment, there is more political pressure for more transparency and accountability than there ever has been. Then we get to the problem of policymakers right now. I can't speak for the other provinces, but for the most part, you know, in Ontario, unlike in cancer and renal care and cardiac care, there's about a $4.2 billion spend each year for which we know very little. That is a massive policy problem. Like, independent of the learning health system, that is a massive policy problem. And how do you justify, you know, added funding? And nobody would ever say this, but how do you justify added funding when you don't have, you know, transparency around the existing funding? So even if you go back to that slide, that middle there, even if you could characterize just the need of individuals and the volumes of individuals regionally, you could start doing way, way better planning and funding and accountability agreements in addition to the outcome measurement that comes in the layer below it. And that's a really important opportunity and can really set the stage for the kinds of funding instead of the historical, you know, having checks go out the door, you know, every year for relatively the same amount, maybe slightly volume adjusted, and that's about it. Like, really doing regional planning is a very important policy setting exercise that we can't currently do. And boy, is it ever needed, just to shed a light on, like, to shine a light on the darkness, right? And then you can think about specific areas where you can adopt the learning health system. But I would say that that's proven to be very compelling to the policymakers in Ontario, to be able to see what they can't see from a funding and planning perspective.
Bob, any advice you want to offer from EPINET?
You know, I think that my three colleagues were very rich in what they said. So in the interest of time, maybe I'll save comments for another question.
Sure. And I've seen quite a few questions coming up about the community sector. And I know several of you have spoken about the role of the community sector. But I'm just wondering if you can speak to both how community has participated in the development of indicators, and I saw you started to answer that in the chat, but also how do we build up the capacity of the community sector to link into this work? And I see a few questions related to that. Anyone want to speak to that? Lisa?
I mean, I guess the community sector being the participants, family members, and service recipients, and that
I think in Canada it would also be community-based service providers.
So That's what is service providers, mental health providers, or other providers?
Maybe I can step in here just for clarity. So there's hospital-based care, there's physician-based care, some of which is hospital-based, and then there's quite a large amount of community mental health and addictions agencies in most provinces who are delivering care, and some of them are delivering early psychosis intervention care. So we feel that it's such an important equity issue that our data strategy is starting in the community for precisely this reason. We feel that it's really important to give them an opportunity to understand and participate in the data proposition. The hospitals know how to collect data. They're not standardized, but they know how to do it. We get billings data from the physicians, but we honestly feel we're starting in the community sector in our data strategy for that very reason, that we want to support the community to have some transparency and an opportunity for quality improvement opportunities.
Thanks, Paul. So maybe one last question. I'm just wondering if any of you can speak to how learning health systems promote equitable services and access and outcomes. And I've heard you speak a little bit about equity today, Paul, but I'm just wondering if anyone else can speak to how learning health systems can help to address the inequities in our healthcare system currently.
I think that it allows measurement. And so you can ask the question and then you get the answer and then you can act. So I think, and we are increasingly asking ourselves that question, and we are asking our providers that question. But if you don't have a structure to get beyond just socioeconomic class, or where you can actually really dig a lot more deeply into what the drivers may be, the learning healthcare system allows you to dig deeper and get the voices and then measure those more nuanced issues that certainly play out in rates of jail and incarceration or police involvement. And so it starts with measurement, but it has to be seasoned and nurtured through the voices and the dialogue.
So here in Ontario, we're thinking very deeply about equity within Ontario Health, and I personally think equity plays out in two different ways. Is your service accessible from an equity perspective? In other words, are all populations getting access? And that's measurable, but not in real time. Like, you have to measure and then you have to course correct. And then once in the program, are people getting access to the kinds of quality of care equitably? And it's the latter part where I think you need to do work to reach populations that don't traditionally access services, to do the equitable access piece. But I think the standardization can go a long way. Of course, you have to, in certain populations, you have to make sure it's culturally relevant and safe. But I feel silly talking about this because David Clark has published kind of a masterpiece that shows that those areas in England that administered his program, that did a better job at adhering to his quality indicators, actually attenuated the impact of marginalization on outcomes, which is another way of saying those who did a better job standardizing their care actually did a better job addressing equities, presumably because the more you standardize, the less opportunity is for the implicit bias and all the other factors that actually play out in the delivery of care. But I really think when we think about equity, we should break it down in terms of access and quality of care, because they're very different processes required to address equity from that perspective.
Thank you. And I'm conscious, Amal, there's more to say, but we're at time. So I just want to encourage everyone to fill out that survey as you log off. We'll also be sending it by email. I also just want to take the opportunity to thank both the GBF staff, specifically Allison and Gohar, for all your hard work in organizing this, as well as all of you for participating today. And last but not least, I really want to thank all of our speakers for giving of your time, sharing your knowledge, and really helping spark an important conversation in Canada. You also gave us lots to think about. You gave us definitions and frameworks around learning healthcare systems, and you also gave us some concrete examples. And I think I'm leaving really with having heard very loud and clear that learning healthcare systems are really about providing the best care, ongoing improvement, and using data to inform care and policy. So thank you all. Merci beaucoup, and wishing you a lovely rest of your day.
Thank you for
Thank
the
you very
opportunity.
much, everyone.